Hello everyone. In OPD, dizziness as a symptom can be very confusing. So it is very important to identify the exact reason for dizziness. And we should focus on the patient symptom ki how patient is describing dizziness. Because sometimes dizziness can represent some serious disorders or it can be a benign condition. In this video, we'll discuss how to approach dizziness clinically. So there are three types of symptoms which patient can describe. First symptom is vertigo. That means ki there is a sense of motion, means ki outside world is spinning. So that will be the important symptom to ask from the patient. Second will be lightheadedness. Lightheadedness means ki patient will feel like head is becoming very light and there is a sort of blurring of the vision or blackout sort of thing is there. And third type of the symptom which can describe dizziness from the patient point of view is a sense of unsteadiness, that is a impaired balance while walking. So these are the three types of the symptoms which patient can describe as dizziness. So starting with what are the disorders which can cause vertigo? So it can be a vestibular neuritis. Second, it can be a very common disorder known as a benign paroxysmal positional vertigo, that is BPPV. It can be a Meniere's disease, or it can be some dangerous conditions like brainstem pathologies. Red flag sign, this is very important. We have to identify the red flag signs so to rule out any CNS disorder in terms of any stroke or in terms of any vertebro-basilar insufficiency. So the number one red flag sign that we should ask from the patient, is there any difficulty in articulation, is there any dysarthria, is there any double vision, or is there any facial weakness? So these are the focal neurological signs. If any one of these signs are positive, then we have to immediately refer the patient to hospital. Drowsiness or low Glasgow Coma scale is there. Inability to stand or walk properly. Atypical nystagmus is there, like a downbeating nystagmus. New onset of headache, and that new onset of the headache is severe or worse in the morning or in the lying down position. So that indicate some sort of posterior fossa tumors. Or if there is a progressive unilateral hearing loss, sometimes patient will not describe this hearing loss, or patient will not be able to give you the symptom of a hearing loss. That will be very important point to be asked from the patient, or it can be detected by ENT assessment only. So these are the red flag signs. Now coming to, if patient gives the complaint of illusionary sense of motion, that outside world is spinning, that is vertigo. So how to approach the vertigo? First thing is ki whether it is a new onset. So if it is a new onset of vertigo, or whether it is a recurrent episodes. So new onset, if it is sustained, then or it is transient. If it is sustained, most likely it will be a vestibular neuritis. Sustained means ki it will persist even if there is no movement of the head or neck. So there will be a sense of rotatory motions, and it can be persist even if the head is still, therefore it is known as a sustained. So what should be done in that case? In that case, only treatment is a symptomatic treatment. Antihistaminic can be given here, and it is self-limiting. If it does not remit within 2 weeks, then MRI should be advised. If it is transient, then most likely it is a vertebro-basilar insufficiency or TIA. MRI should be done immediately, and we should assess the red flag signs in this condition. If it is recurrent, then we'll ask the history of hearing loss, or if there is a tinnitus, like ringing in the ears, of or if there is any fullness in the ear. So these symptoms will describe the patient as a patient of Meniere's disease. ENT referral should be done. Second is if it is provoked by any change in the head movement, like we have to ask the patient history ki while rotating the head or neck movement, the this dizziness is increasing. So most likely it is a case of a benign positional vertigo. So ENT referral will be done in that scenario. Now, the disorders which cause pre-syncope or lightheadedness like blackout episodes, these can be a vasovagal attack, it can be arrhythmia, structural heart diseases, can be orthostatic hypotension, or it can be metabolic conditions like anemia or hypoglycemia. So, vasovagal. So, vasovagal means ki it is triggered by some episodes like intense emotional stress. So you must have heard this history ki like there was some tragic news in the family and the patient just have a dizziness episode, fainted or have blackout. So that is intense emotions. Or sometime what happens when the technician is taking the blood sample, the patient have a vasovagal attack, that also is included in this list. Prolonged standing, like in the school assembly, the children, they are standing for a long time, they collapse, so that is also vasovagal. Prodromal feature will be there, like just before the episode there can be an episode of nausea, sweating and disturbance of the vision. Arrhythmias. So arrhythmia, patient will complain ki there is a episode of palpitations. It occur at even at the rest, and there will be a past history of myocardial infarction which has triggered the arrhythmias. And when we do the ECG, sometimes ECG can be normal or it can be abnormal ECG. For arrhythmia, if it is a transient arrhythmia, it is very difficult to diagnose. Maybe we can advise for Holter monitoring. Even in 48 hours Holter monitoring, it might not be picked. So careful history taking is important. Structural heart disease can present as a exertional syncope, like during the exercise there is a syncope attack, fainting episodes, blackouts that occur most likely in cases of aortic stenosis or hypertrophic obstructive cardiomyopathies. Murmur can be present, so we have to auscultate the patient to look for the structural heart disease. Family history of sudden cardiac disease, very common in HOCM, hypertrophic obstructive cardiomyopathy. Or we have to watch for the heart failure signs, like crepitations are there, or S3 sound is present, JVP is elevated. For orthostatic hypotension, this is also a very common condition, and there will be a very important point here, that there should be a relationship between the lightheadedness and standing up. When patients stand up, so there is a dizziness. So that is a very important point to catch. Demonstration of a significant postural drop in the clinic, we have to check the blood pressure in a supine position, then ask the patient to stand up, then we will check the blood pressure again. So the definition is significant postural drop, systolic BP fall by more than 20 millimeters and diastolic BP of more than 10 within 3 minutes after the standing position. That is very important. And three important causes of orthostatic hypotension are dehydration, very important cause, dehydration due to diarrhea, vomiting or maybe excessive sweating. It can be antihypertensive drugs, especially alpha blockers, or in elderly it can occur because of any antihypertensive drug. Autonomic disorders like due to diabetic autonomic neuropathy. Metabolic causes are anemia and hypoglycemia, which are very easy to detect, like pallor will be positive, hemoglobin will be low, and in hypoglycemia patient is taking anti-diabetes medications and skip the meals, so hypoglycemia present, that also present as dizziness. Now the disorders which cause unsteadiness can be some drugs or toxins, ataxia due to cerebellar involvement, it can be multifactorial. So drugs and toxins which can cause dizziness or unsteadiness, alcohol, antihypertensive agents, alpha blockers, benzodiazepines, haloperidol, it can be antidepressant agents, anti-seizure agents. Ataxia, in ataxia if there is a cerebellar involvement, there can be a broad-based gait which is easily identifiable. Inability to heel-toe walk, we ask the patient for a heel-toe walk. Intentional tremor will be there, past pointing will be present, or this arthria can be present. Nystagmus. Multiple factors like weakness, sensory neuropathy or impaired proprioception can be there, and these are mainly present in elderly population. While summary, so if a patient comes to your OPD, the most important point is we have to identify red flag signs. So red flag signs are very important. Patient says कि there is dizziness, चक्कर आ रहे हैं, तो just ask those red flag signs: dysarthria, diplopia, facial weakness. Then if there is any drowsiness, new onset of headache, worse in the morning hours, you have to check the patient. If there is any focal neurological deficit, Glasgow Coma Scale we have to assess. Nystagmus has to be assessed in all the patients of dizziness. If any of these red flag signs are positive, we should refer the patient for hospitalization. If red flag signs are not present, then ask the patient what exactly is dizziness. If there is an illusionary sense of motion, like outside world is spinning, so this is a case of vertigo, and in vertigo we'll follow the same protocol whether it is a new onset or whether it is recurrent. Then if there is pre-syncope, like patient has some sort of blackouts, or if there is unsteadiness, then pre-syncope will be because of orthostatic hypotension, vasovagal, or it can be because of use of some drugs. Unsteadiness is usually multifactorial or effect of some toxins like alcohol. So we should proceed systematically, so that we should rule out serious conditions, and we will be able to identify the benign condition where there is no indication for hospitalization, and appropriate treatment will be started. So if you have any doubts or any questions, you can put in the comment section, and you can also share your valuable feedback, or maybe any case, interesting case of dizziness which you have identified as a case of vertigo or some pre-syncope or unsteadiness. You can also put in the comment section. Thank you.